So hello everybody, and thank you very much for joining us. Uh, Great to have you again. Uh, Today's session is with Richard Harvey. Richard is from Sydney, and I have known Richard for almost, I would say, 12 years, and participated with him with quite a few educational activity. What I like about Richard is his love for his students and teaching. And it hurts him when he sees things done wrong. And he really loves it when he teaches somebody a new trick. So I think you're going to enjoy his talk. He just joined us just now. Let me just unmute his microphone.
Hi, good morning.
Hey, Richard, how are you?
Good, thanks.
Good to see you. Is that something? Is that something real, the image behind you, or is it just, it looks so suspicious. It looks like.
It's just a graphic overlay. You love a bit of ciliated respiratory mucosa, Moaz.
Well, one more time, we apologize for keeping you up. We're trying to try different, we're going to be trying to have different time slots for different speakers. But I was just before you joined us, I was just telling the crowd the fact that you really, really love to teach, really in the same tradition as Heinz, and that you really hurts you when you see things done wrongly, and you really love it when you teach somebody a new trick. So thank you again for joining us. I really appreciate all of your engagement in the education of ENTs around the world.
That's very kind of you, Heinz. Moaz, thank you very much for having me again. Let me pull up there and I'm going to share my screen. You want me just to get straight to it?
Sure, please.
So you should be able to see my screen. Frontal sinus surgery techniques. You got it?
Yes.
Now, I apologize. This is Zoom. I've got a good internet connection, but this is sort of video heavy, this talk. So hopefully it all comes across okay. Now, I'm going to talk about a technique that we've been doing more and more lately. It started off once again for many of my talks and techniques that I do now is it stems from my tumor practice. Being able to do tumor surgery in which we can see the frontal sinus, we started just to drill out the nasofrontal beak on one side. It's not a lothrop, it's not a hemilothrop. It is really this technique called Carolyn's window. And forgive the Japanese here, it's from a talk that I gave. But it's all about making it easy. And let me take you through the evolution of this approach. You know, a big part of this approach is the fact that I like to use this. This is the 0-degree endoscope. Now, you know, maybe I'm not a very good, 70-degree endoscope user, but so often I need straight instrument access in the frontal recess, in parts of the frontal sinus. And a lot of this has got to do with tumor surgery. You can look around the corner, but when you start to use curved instruments, you are down to often a picking and scraping technique. I can do inflammatory sinus disease that way, but it becomes increasingly hard to do tumor surgery properly that way. And so I want to take you through how we've evolved this technique. And I think if I show you how we've evolved it, you'll understand what we're doing now. So this is a patient who had a giant osteoma. And when they came back 8 years later with some frontal sinus dysfunction, I really wanted to create a very big opening. And so I said to my fellow at the time, this is 5 or 6 years ago, I said, let's just drill away the wall in front of the Agenasi. It's not an auxiliary flap like PJ Wormel does. It's not simply just taking a bit of a keratins to the front wall of the Agenasi. It was really drilling away, and you can see we're drilling out to the periosteum and the nasolacrimal sac and drilling the whole wall off right to the very top of the nose. And I did it because I wanted access to the frontal recess and I wanted a 0-degree access. And I've forgotten why at the time, because there was some scarring, maybe there was an exposed anteroethmoidal artery. But I did this approach And when I was doing it, I thought to myself, well, you know, that certainly lent itself to this axis. I'm still using a 0-degree scope. Very important when you see this video. This is a 0-degree scope. This is a straight quad cut being used in the frontal recess. And all I've done there is just remove the wall to the frontal, to the agonasi and the frontal recess. So if you, once again, that's what it looked like to begin with. And this is what it's become here. So it's this part of the bone. It's sometimes being referred to as the frontomaxilla and agonasi complex, but it is just this sort of hard bone that sits in front of the frontal recess. Now, where this started for me was dealing with hypoplastic sinuses. You know, we all understand, what do we do with someone who's got a very small frontal? Well, people who had a very small frontal, you know, who had disease. This is a very typical patient who's had sort of limited surgery. And I can, you know, in people who have inflammatory disease, limited surgery often just leads to this scenario where there's mucus secretions and trapping. But here he is after the operation in my hands. And what we've done here, whoops, my apologies. So here we are here after the surgery. And you can see up here, there's probably a little bit of crusting down there, but you can see a nice opening into the top of the ethmoid. And we've achieved that over here just by creating this Carolyn's window here, where you can look straight in and see the frontal recess. We'll go to the other side. You can see what the other side looks like on the left-hand side. And here it is post-surgery. There isn't really much of a frontal recess. And all I've done is just drill away the bone, and I can see now the posterior table. Now, that's how we started it. So here's before and after a procedure. Now, I'm having just a very slight trouble with my PowerPoint here, so forgive me here. Now, what's being removed when we do this approach? I want to show you here that this is the midline sagittal view. We're not really drilling in the midline, are we, when we're doing frontal recess work? We're really off to the parasagittal side. And here we are now. So this is a parasagittal view. Now, in the classic teaching of just removing the front wall of the agonasi, this is the sort of bone that we're removing. Removing the front wall might be doing this. This is just where you maybe make a flap and you do a PJ Wormald's technique, you just do a few keratins, or Jim Palmer's technique of just kerating through the front wall. And then you see into the agonasi. That's not really what we're doing here. We're removing the entire nasofrontal bone here on that side, but just in the alignment of the actual frontal recess. And we're doing it from front to back. Now, let me show you another example here that takes us through how we're doing it. This is a patient with CCAD, a central compartment atopic sinus disease. It's maybe a topic for another day, Moaz. But this person's got very bad allergy and was getting terrible barotrauma. So let me take you through his operation here. So he's got this sort of a mucosal edema and thickening and barotrauma occurring. So we're going to do here now, this is one of our early patients. We're going to do a complete sphenoethmoidectomy. This obviously fixes his barotrauma, at least in the rest of his sinus cavity. And then we're going to come and we're going to remove this little bit of mucosa off the front wall of the agonasi and the front wall of the frontal recess. And then with a drill, we're going to get in there and actually drill away the bone. And I hope it's not too staggered when you're watching it, but it is sort of slightly sped up on my end. And we're going to drill out until we find the periosteum. And then just between the periosteum and the middle turbinate, we're just going to remove the bone. And eventually then, once you've removed the bone, you can sit there with just a quad cut and simply just remove the bony partition so that at the end of the case, you've got this view here where you can see the corner pocket or the optic nerve all the way up here. There's the anterethmoidal artery, and we're seeing right up to the frontal recess. Now, all I've done here, and then I used to put little free grafts in. Here we are now. And I put a sponge in. And this is how we started doing this technique. Now, those free grafts used to take really nicely sometimes. Here's the patient, I think 3 weeks out. A bit of crusting there. The free graft didn't take very well. But these patients down the track, you can see the frontal recess is nice and open. bit of granulation, drilling a bit of bone and leaving behind a bit of granulation is always going to leave issues with long-term healing. But at least in this person, you know, you look at them a year and a half later, 18 months, you know, all that granulation disappears and they've got a pretty good looking sinus cavity. And when you look at it, it's like you've just got a giant middle meatus, like someone's had a very favorable middle meatus. Let me take you through then how that's evolved. So then here's someone here in which very similar story. And here's what they are look like post-surgery. So we started doing this technique and you can see there, we're just looking with a 0-degree view. So you can actually just see straight into the frontal recess. It's like having a giant middle meatus, a very favorable anatomy that's allowed you to just simply stare into the frontal sinus. When I first started this, I was just doing it with free grafts or nothing at all. And then we started adding the concept of a mucosal flap. So here's one of the early versions we did it on, where we used to make the same incisions. And perhaps in my first iterations here, I made it anteriorly based, thinking it's sort of like the reverse of PJ Wormold's axillary flap. I'll just do it coming forward. And we'll fold that back, and then we'll do the drilling here. And we'll drill this area here now and actually remove the bone and find the periosteum laterally. So that's the first thing we do, is find the periosteum and the nasolacrimal sac on the lateral side. And then you just stay medial, or so I should say lateral to the middle turbinate and medial to your periosteum. So you can see that you've always got the frontal recess behind you, and we'll keep taking this bone until we really remove it. And by doing so, it means then that you're left with the frontal recess partitions. You can use just a kerosene punch. I'm still using a 0-degree, but I'll finish it off sometimes with a baby Hoseman to come around the corner. And then I'll fold this flap back. Now, I've sort of edited that video because it's a little bit awkward. Here we are at the end of the case. There's a full house vest. We look up now, 0-degree scope, just looking straight up, and we can look straight up into the frontal sinus on one side. And there's no doubt about it that when we started adding a flap to this technique, we got much, much better results. So once again, we just put a little sponge finger. We still had a little bit of raw bone, so I was still often putting a little free graft as well. But now the free graft was just covering a small area. And I'll show you what these cases then look like down the track. Because once we started preserving the mucosa and leaving behind this little rotational free flap or anteriorly based flap, things started healing really well. And so gone were the granulations that we saw initially, and we were getting these sort of sinus cavities very, very early on in the piece without the sort of crusting that we would see before. And you can see that looking up with this 0-degree view, it really is this concept that it's like having a giant middle meatus, right, and just a very favorable anatomy in this young girl. With the person's actually got sort of mild eosinophilic CRS, and therefore we didn't want to do a Lothrop. We didn't thought it was maybe overkill. And this is the sort of approach that we take now. Now, I was showing this technique at one of my courses in which Brad Woodworth was there. And he shook his head and he said, "Richard, what are you doing? You know, you need to base that flap inferiorly." And he would make this little strip of mucosa based inferiorly. It would fold out of the way a whole lot nicer. And I thought, Brad's absolutely right. I saw him do some techniques, but I didn't like the idea of making a cut in the middle of the side wall of the nose. And so this is what we do now. So this is very close to our current technique. There's one or two small changes, very close. So we make this inferiorly based flap, but it comes all the way to the piriform. So we take it now all the way to the piriform and then down here again. So we fold it back now. This is folding it all back. So you're actually folding away the mucosa over a lot larger segment now, but it actually returns a lot nicer. See how it's inferiorly based? And then once it's inferiorly based, it's a little bit easier to drill, go and find the periosteum out laterally. And the nice part about this, Moaz, is that with high-speed burrs, this is a 30K 4 mm burr, the whole thing happens very, very quickly compared to how we used to do frontal sinus surgery of old. And you can see here now, I'm just coming up to the very end of the nasofrontal complex, all done with a 0-degree scope. There's a little bit of partitions here left in the frontal recess. I'm just going to thin this bone down a little bit more. So I've got that nice sort of flat middle meatus. And then you can just put your quad cut in here and just tidy up the partitions. And this is an example of that whole flap goes back up. You still have a little tiny bit of raw bone on the inside of the inside of the nasofrontal beak, but that whole inferiorly based flap makes a huge difference. And here we are now post surgery from this sort of approach. Occasionally get a little web like that, but the rest of it ends up being this sort of very well healed middle meatus. And once again, we're just looking with a 0-degree scope here. And this affords the surgeon great access above anything in the ethmoid, the ability to sort of work with a 0-degree scope and avoid angle instrumentation. So here we are. Here's a current technique. I think this is, I have to thank one of our PhDs, Dishapong. He put this together right now. Here we are right to the very front there. This is unedited, Moaz. So it's a bit sped up, of course. I don't operate this fast, but it's a bit sped up. But I'll show you then how quickly everything develops because it's unedited. And so we just taken the drill here. And you think about all the things I used to do during a draft 2A, because that's all we're doing here. We're just doing a draft 2A, but we're just doing it by removing that bone in front of the frontal recess. So we're just going to take off the front wall, the frontal recess. Here we are there. See how I've found the periosteum? I'm staying entirely lateral to the middle turbinate. And here we are now. You just quickly drill it. You know that you can't do any harm there because you've got to come through the frontal recess before you get to the skull base. And there we are now, a little bit more bone. And once you're committed to this approach, see how I've kept on going here? Because once you remove the bone, you actually create less raw bone by taking the bone aggressively. And so once you take the whole complex out, you really have actually less bone exposed than if you sort of were to stop halfway through. So here we are now, and it's not a hemilothrop. It really is just taking the sort of concept that I think my colleagues, PJ Wormel, Jim Palmer, were trying to do with auxiliary flaps and kerosene techniques, and really changing it with the powered instrumentation we have today. So it's just being able to extend that concept. So you've got this really great 0-degree access. And that's a sort of a front to back example of doing it. Now, I'm very thankful for Claudio to send me this slide. So he was involved with PJ and Alki Saltis and my colleagues here and internationally with the new frontal sinus classification paper. I'm not on that paper, but they had this concept here that, you know, frontal sinus dissection was made difficult by how much pneumatization and different cells encroaching into the frontal recess. So this is your down or vertical axis. And then it was made difficult by your AP diameter. Well, the nice part about doing this Carolyn's window technique is that you're really getting rid of the AP diameter concept. So you're taking away this narrow AP diameter concept, and therefore frontal recess surgery really just boils down to this, just how complex the cells are. If you remove the front wall, you get rid of the AP diameter issue, and then you can just simply deal with the complex pneumatization pattern of the frontal recess. And then someone asked me, he says, does it actually give you better irrigation, better topical penetration? Well, that's only recently just come out. So this was Jonathan Overdyst and some colleagues in America did a cadaveric model to show that the nasofrontal bone axillectomy, that's what they called it, and they actually looked at it with a draft 2A sinusotomy done through, and they put a little trephine in the frontal sinus, and they looked at the draft 2A frontal sinusotomy, and they did the draft 2A where they removed the bone that I'm talking about. They called it the middle turbinate axilla agonasi complex, or they did it all with sort of 70-degree angled instrumentation. And what they showed is that when you had the sort of big middle meatus that I showed you before, that there was actually greater irrigation penetration and distribution to the frontal sinus than when the irrigation has to do a sort of a 70-degree turn and up the natural frontal recess. So whether or not this translates into clinically meaningful differences, who knows? But right now, what I've shown you here is a technique, what I call really, it's an axillectomy. So it's a removal of the axilla. And we refer to it as Carolyn's window, who was a fellow with us at the time. It's all about providing 0-degree access with the endoscope to the frontal recess. It makes frontal recess surgery really simple by removing the AP diameter issue. The Woodworth flap, or the modified version, creates rapid healing. It's certainly something that adds to it. And it gives you this just really giant middle meatus appearance. It's great for tumors like inverted papilloma or osteomas that are sitting in that frontoethmoidal area. Barotrauma cases are great, central compartment atopic disease. But I must say, for people who have very severe eosinophilic disease, I still do a draft 3 because there are limitations on how big an opening you really get here. But great for all those other sort of, non-severe hypersecurity conditions that we treat. Anyway, look, I just want to wrap up there and say thank you very much. I do have a YouTube channel and some on social media things where we post some of our lectures, and I'll certainly aim to put some information up there if anyone has any questions. But I thank everyone for their time and interest today.
Thank you, Richard. This is too short. We're expecting an hour lecture.
Oh, you want an hour?
You gotta get us more. Get us more.
Yeah. Okay. You'll have to hit me up with some questions then.
All right. So hey guys, so you need to have engaged Richard with some discussion here. If you want me to open up the microphone, please wave your hand.
I'm sorry, I could have made it longer.
So let me just say that Richard, John Delgadio is going to be speaking to us soon. We haven't set up the date yet about the central compartment.
Atopic sinus disease, yeah.
And maybe I'd like to invite you, maybe get your perspective on his talk and see like you could engage in a discussion. But I mean, do you consider that a surgical disease, or what's? I know we're going to discuss later, but
yeah. So it's not really the central compartment atopic sinus disease is this condition in which, look, Moaz, I'm going to do it, right? You want me to give you like the 10-minute?
That'd be great. Yeah.
Going. I've mentioned it here, so I might as well, give you like my 10-minute blast on what I think. So give me 2 seconds to open it up. I'll produce a talk on 0 notice. Okay. So I'm going to give you 10 minutes on what is, can you see my screen?
Sure.
You got it? So I'm going to give you a quick talk on what is the radiologic phenotype of CCAD, and maybe this will spark a bit of debate as well. So I'm going to talk to you about when sinusitis is not sinusitis, and I'm going to show you here over the next few slides that this person here who comes to you with an image like this, where there's just thickening along the medial edge of the ethmoid, a bit of mucus trapping, actually doesn't have sinus disease as their primary problem. And let me explain this to you. So we all know that there's different phenotypes of disease that we treat. And I love this photo because this is Sally Wenzel's photo, that she described that in younger adults and in children, we see an allergy-mediated Th2 disease. And this is this young adult childhood asthma patients which really have an allergic process going on. And when I say allergic, I don't mean eosinophilic, I mean truly Ig-mediated classic allergy that's driving their symptoms. And these are the patients who'll come and see you and say, Richard, I've had allergy my whole life. And you look in their nose and you see this. So this, Moaz, is not polyps. This is middle turbinate head edema. Some people have described the loss of the cleft here. It can be even polypoid like this, and it can just be swollen. I've given you very obvious examples. but this is edema of the middle turbinate head in relationship to allergy. John Delgadio actually described this initially, but Anisa Hamazan, who works out of Malaysia, did all the research behind it. So this is one of her publications where she looked at what is a normal middle turbinate, these top two, and then you can see little focal areas of edema, diffuse edema down the bottom left, and polypoid edema. And what she showed was that if you have diffuse or polypoid edema, it is an incredibly strong positive predictive factor to having allergy. It's not necessarily sensitive, but if you see it, it's an absolute sign that you have inhalant allergy. And it can be bad, Moaz. So here's a patient who sent to me with bad polyps, but have a look. The polyps aren't in the sinus cavity. The polyps are actually coming off the middle turbinate head, off the superior turbinate head, off the nasal airway structures. This is an example of exuberant polypoid edema coming off the turbinate and septal structures. They can present as a grade 3 polyp in the nose, but they've got a completely normal sinus cavity. This is not nasal polyposis as we know it. This is simply a marker of inhalant allergy and polypoid edema coming off the turbinate structures, in particular the middle turbinate head.
One of the way I make the diagnosis is a huge discrepancy between the endoscopic finding and the CT scan. On the endoscope,
yes.
I think that you're gonna see.
I'm gonna channel that comment here in a moment, right? Because that's a good one. Because if you understand what is turbinate head edema, and it's not just our group who's shown turbinate head edema to be a marker of allergy, you'll understand this. So this is John Delgadio's central compartment atopic sinus disease. Because once you get really exuberant middle turbinate and septal edema and polypoid change, your sinuses begin to look like this, where you get this central thickening here in the nose, and the peripheral sinuses are essentially normal. Once again, look down the bottom right-hand corner here. The superior and lateral walls of the sinus are completely normal. So once again, Anisa Hamazan, I've got to give her a huge shout out here. She put the data then to John Delgadio's observation. She looked at 106 patients. She classified their sinus disease as no thickening, medial or limited, diffuse, or complete opacification. And she did a whole lot of different types of scoring of patients. And she broke the group up into those who were non-atopic and those who were allergically sensitized. There's not a huge amount of difference here in the groups, apart from the allergics being slightly younger, as you might expect. And she looked at a whole lot of different models and many different ways of looking at the thickening. And she actually came up with this phenotype B1, which actually is exactly what John Delgadio described. So statistically, this concept of a centrally limited and superolateral sparing of the sinus cavities is actually a great sign for allergy. And in this situation here, when she used the CCAD B1 phenotypes of the central compartment, it actually predicted allergy in 60% of patients compared to 40%. Now, someone said to me, Richard, oh, that's not that big a deal, 70 versus 45, that's not a huge difference. But if you actually think about the background rate of allergy here might be 20 or 30% of the population, and then the fact that you can predict someone's allergy status based on the appearance of their CT scan, considering all the confounding factors that are involved here. These were all primary patients, obviously, who never had surgery. But that's an amazing feature, I think. So this is one of the first studies, but you mustn't believe any one single study about it. And Ed McCool published on something very similar out of the States. So he coined it middle turbinate polyposis is different from sinonasal polyps. And so he took these two groups. You can see this patient here, Moaz, has got true nasal polyposis. And then this person here has got middle turbinate polyps or middle turbinate edema. So this is the allergic person here. And what he showed was that those who had middle turbinate head edema were slightly younger, 35 years of age group compared to those with true polyps. And that's what we see clinically. Patients who have central compartment atopic disease have an exuberant rhinitis and they present early with sort of a story of I've had sinus my whole life. Whereas true eosinophilic polyposis and adult onset asthma really occurs in the 40s and 50s. Interestingly here that the middle turbinate polyp group was highly associated with allergic rhinitis, no suspicion there, and less so with severe asthma disease. But most importantly, channeling your story, Moaz, is exactly what you were saying before, that the Lund-Mackay score for these patients was actually very small. Exactly what you were saying, because it's all about having just mucosal thickening in the medial or central compartment of the nose. It's not a diffuse sinus disorder that's occurring throughout. And so it's not uncommon now that, you know, my fellows will leave our fellowship. And this is one of our fellows over here on the left-hand side. He was sent this patient who's 19-year-old female with childhood asthma, was sent to him with chronic sinus disease. And you can have one look at the scan now here on this left-hand side, and you can see that all the thickening is just related here into the medial or central part of the nose. And this young girl does not have sinus disease. What she has is this central thickening related to chronic inhalant allergy. Now, just when I thought that, with John and I had touched on something, that was sort of going to be semi-novel, Valerie Lund was listening to one of my talks and said, Richard, that's the black halo sign. And it's very true. You get this black halo of normal sinuses around this thickening here. And she said to me, I've described that. She never published on it in an original article, but sure enough, when I looked up her books, here it is. It's in actually investigative rhinology. Valerie describes it as the black halo sign, and she even put a beautiful example on the cover of her book. And so when you look at the cover of the book, she's got this beautiful example of what is central compartment atopic sinus disease, someone with this central thickening who's a young person with an atopic story. And what this person is really a patient with exuberant allergic rhinitis. They have an exuberant allergy, and that's really their primary issue. Now, Moaz, it's not to say that they don't develop sinus dysfunction. They do. They start to get a mechanical dysfunction of the sinuses. These patients often present with barotrauma and sort of secondary sinus dysfunction, but that's what it is. It's secondary sinus dysfunction. And they often have their smell preserved very, very long and late into this condition. Whereas we all know that those patients who have adult asthma and adult polyposis lose their smell very, very early. And that's very different to this classic ECRS group, which is not a simple allergy. And I must remind everyone who's listening, you only have to look at someone who has true adult onset polyps and asthma to see that their middle meatus is very different. This is someone who has significant eosinophilic airway inflammation that's not driven by allergy alone. And I touched on this in my last talk. I said that in the new EPOS criteria, they've actually included this as a type of diffuse Th2 driven sinus disease. And I think it's fair enough, even though it may be really an exuberant allergic rhinitis, you do get secondary mechanical sinus dysfunction as part of it. And therefore that's why it appears in the new EPOS criteria, and it's certainly over here. It's certainly something that's got a lot of merit behind it, and data to show that this is really quite a unique phenotype. And I think maybe here, Moaz, it might come down to this idea that, I'm going to skip through this. This is not relevant, but just really to talk about the idea of, you asked me before, how do I manage it? Is it not a surgical disease? It's a great surgical disease to treat, because surgery really cures you of all the mechanical sinus dysfunction. But if you don't control the underlying inhalant allergy, what happens to the nose is that you get this terrible edematous change again around the entrance to the middle meatus. And I bet you there's a lot of ENT surgeons listening now who've had these patients over the years. There's two ways that you're introduced to CCAD. They're the patients who you take to theater, who've got terrible nasal polyposis, and you remove the polyps, and then you suddenly get into the ethmoid, and the ethmoid's plumb normal. The minute you see that, and there's no thick eosinophilic mucin everywhere and everything else, this is a patient with CCAD. And then the other time that ENT surgeons will know they've come across CCAD is when you've had those patients in which you've done their surgery years ago, a couple of years ago, and they return to see you complaining of symptoms, congestion, discharge, pressure, and you look in and it looks terrible. The head of the middle turbinate, the middle meatus looks all swollen. And then you put your endoscope through and it's a perfect looking ethmoid. That is an example of someone who has central compartment atopic disease, because all that's happened is that without treatment of the allergy, the middle meatal area just becomes really inflamed and gets the same polypoid degeneration again. So I'm going to leave it at that. And maybe I've given like 2 short talks now, and maybe we can open up the floor for questions.
Sure. Going back to the frontal sinus, Dr. Nuri is asking, I don't know if you see, can you see the chat line? Is asking about the use of drill versus.
Let me pull up the chat. So hello, sir. Where's the drill question? I can't see it.
Oh, he sent it to me privately. I don't know why he did, but it says,
okay.
Do you have,
read it out to us.
Okay, do you have to use drill, or can it be done by pop technique using the punch forceps?
No, you got to use it with a drill. This is when I show it. I think my videos don't really demonstrate how much bone you're really removing. It's a lot. And so to me, it really is a technique of using high-speed drills. It's not something I could have done before the era of 30K burrs. And so while I'm sure you can find a patient in which you can maybe do it with a hand instrument, 90% of patients, you need to have a drill to do this operation. Can I answer one of these questions here? Is there any, someone said to me, please clarify where I do Carol's window versus standard frontal. So that's a good question by Tessa. So Tessa, I actually don't do draft 2A surgery with angled instruments anymore. I don't do it ever. It's not as if I reserve this technique just when I'm doing tumors. If I'm going to do a draft 2A frontal recess clearance, I do it the way I showed you in the video. So I do that now for everyone. So I make that approach for everyone. It's much, much quicker in my hands than using angled instrumentation. And it's become now my standard. Someone asked me, why does CCAD affect the head of the middle turbinate instead of the axilla? Yeah, it affects the axilla and the middle turbinate. You know, I guess the middle turbinate is where we see it the most, but you'll see it coming off the uncinate and around that area and off the septum. And it's not really about, you know, it's where we believe that inhalant allergens deposit and sit, you know, when they come through the nose, that they deposit in this area. And because as the airflow decreases here, you know, large particles drop out. And we think that they deposit around the middle meatus, around the head of the middle turbinate and on the septum. And that's why we get that polypoid change. Yes, so is there a difference between medicinal approaches to nasal polyposis and CCAD? So this is a really good question. This was through Kushid. So this is a great question because it's a whole separate talk. If you want to go to my YouTube channel, I do talk about that. CCAD to me is an exuberant allergic rhinitis. You can trim the middle turbinate edema away. At the very least, you would need to do a limited FES. But if I'm going to give someone an anesthetic, Moaz, I just do a complete FES for them. But I don't do all sorts of lothrops and everything else. But prior to surgery, I talk to these patients about the nature of their problem, and it's all about their inhalant allergy, and I start them on immunotherapy. You cannot, in my opinion, just simply stop the changes occurring by giving people a bit of Nasonex or Rhinocort afterwards. It's not something that you can suppress this allergic edema by a bit of pharmacotherapy. You really need to get on top of the allergy properly. And I don't know why. I think if that's got something to do with the fact that this is the pointy end of the spectrum for inhalant allergy, people who get these sort of changes. But you really need, in my opinion, to start immunotherapy, which we do for CCAD patients. Once they're on it, 3 months in, then I do their surgery, and I try to get them through a course of immunotherapy as part of it. Whereas Nasal polyposis is all about creating a big neosinus cavity using corticosteroid irrigations. You don't have to use a whole lot of corticosteroid irrigations for CCAD patients. And that's where biologics come in for the nasal polyposis patient. Let's go down. Yep, what were you going to say?
Is there any role for oral steroids?
Yeah, so I've got this general rule. If you said to me, Moaz, what the errors that I've seen in the use of oral steroids is that if you're going to take someone to surgery who's got an inflammatory disorder, I believe, and many of my colleagues, Brad Woodworth, Jim Palmer, Rod Schlosser, we all use quite a lot of oral steroid at the perioperative period. So we, in the immediate period after surgery, I give my patients, not huge doses, 25 milligrams about the maximum they get, but they will get it for weeks, 4 to 6 weeks, until their sinus cavity is stabilized. And then I leave them on local treatments. If you let the sinus cavity become edematous and it never comes good because you only wanted to give 5 days of oral steroids or 4 days of oral steroids or 10 days, you will never get a good cavity to heal. It has to heal once where the mucosa is quiescent and in remission. If you never really get to that point, it's very hard to get it good. So that'd be my comment about oral steroids. You've got to use it enough. What's my formulation for steroid douching? I see another question here. I use 1 milligram of betamethasone per 240 mils nasal irrigation. I use 1 milligram of budesonide, and I use a 2 milligram mometasone solution. So these are the 3 different solutions, all in 240 mils. What's the next one? Oh yeah, what are the chances of complication? Yeah, so look, it's true. You are drilling laterally to find the periosteum and the nasolacrimal sac, and so of course you could drill through those structures. But if you use a diamond burr, it's very hard to injure the soft tissues. So I actually see it as a really safe technique. I think it's much easier to pinch those structures, and certainly the nasolacrimal apparatus, Moaz, has suffered at the hands of a few backbiters. So the actual diamond burr is actually pretty safe when it comes to drilling that. But yes, of course, you've got to go looking for that lateral limit to understand where you need to drill. Does CCAD associate with other atopic diseases, eczema, asthma? And that is a fantastic comment, because it absolutely does. If you have inhalant allergy and it's quite bad, then you often will have or allergic symptoms or atopic symptoms at other sites. Importantly, at your conjunctiva, your skin, and your history will be of childhood asthma, not adult onset asthma. And then, does optimization of CCAD similar to nasal polyposis prior to putting up for surgery? Now, this is something that I think will reflect people's individual practice patterns. I don't give people a whole lot of perioperative steroids and medicines before surgery. They just don't get anything. They just come to surgery. There's reasons I do that because of research and various things. I don't want them to have a whole lot of steroids involved, but I've never really needed it. Although when I have people who like to give patients perioperative steroids, that's not a problem. It certainly improves the conditions, and I think that's totally fine. But I would probably say that if you're going to give perioperative steroids, you don't need to give as much for CCAD than you would for true nasal polyposis. And I really would rather invest the time in getting them started on immunotherapy 3 to 6 months out at the CCAD patients prior to surgery, because it tells me that the patient's really interested and engaged in at really addressing the underlying problem here, which is inhalant allergy. I think I'm up to date now with the questions.
One more question from my side.
Yeah.
Like, why do you think the middle turbinate is the site of? Is it the airflow, the pattern of airflow, or is it there's an element of contact, inflammation? What's
No,
your?
I think it's purely just where inhalant allergens deposit.
Okay.
I think, and Moaz, it's not venous sinusoidal tissue that is like the inferior turbinate, which just becomes congested and hypertrophied. The mucosa over the septum and middle turbinate uncinate, which is where this disease occurs, is very, very thin. It's just a mucosa on bone. And then once you get an inflammatory reaction and you get that fibrin cross-linking that occurs that then forms the polyps, This is why there's not much space there. It's just mucosa on a hard bone surface or a hard cartilage surface, and therefore that's where they deposit the allergens. That's where you get an allergic reaction.
Great. Thank you very much, Richard. I still need an explanation for that picture behind you. Is it like electron microscopy of something?
Yeah, it's EM scanning EM of the respiratory mucosa with some cilia. Taking a bit of a 3D.
All right. Okay, great. Thank you again, Richard, and have a good night. Sorry again to keep you up.
No, my pleasure.
Enjoyed having you. And so join us. Thank you for joining us, and we join us tomorrow, where Dr. Anis Samo from New York is going to ask a very pertinent question. Whatever happened to reflux? You know, a few years ago, everybody was talking about reflux, and now nobody wants to talk about reflux. So she's going to take a fresh look at this, and I think you're going to find it a very enjoyable talk. Thank you again. Have a nice evening, and I'll see you tomorrow. You take care. Bye, Richard. Richard is gone already, gone to bed. Take care. Bye.